Good evening, everyone. It gives me immense pleasure to welcome you all to another session of GynoScope, a collaborative academic initiative brought to you by Dr. Aditya Nimbkar and SIMSOG. GynoScope is a unique series envisioned with a singular goal to create a space where young medical minds can come together to learn, question, and grow in the field of obstetrics and gynecology. Through GynoScope, we aim to bring you a range of clinically relevant case presentations, real-time discussion, quiz-based learning, and unique formats like Dr. Nimkar's Brain Benders, which have now become a favorite among many of us. Today, we have GDP Sampritha and P. Hemanth Reddy from Sri Devaraj URS Medical College, Kolar, to discuss on the case about hypertensive disorders in pregnancy. We're so grateful for the enthusiastic participation from colleges across the country and for the opportunity to build a stronger, more connected academic community. Thank you so much for joining us today, and we look forward to an engaging session ahead.
Thank you so much, Harini, assuming it was you, for that wonderful, highly enthusiastic, energetic introduction. That was amazing.
Thank you so
So,
much, sir.
that was sarcastic. Anyway, so can we begin?
Absolutely. Sampritha and Hemant, you may feel free to share your screen and start the presentation.
Okay. So, by the way, something that I'm going to do today, now I'll be sharing my notepad as well intermittently, and I'll be sharing notes. I'll be writing a few things that I believe are going to be better off read as well as being heard about. So, that is what I'm going to be doing today. So, let us begin. Do we have the presenter, Sampritha?
Yes, good evening, everyone. I'll just be sharing my screen in just a second.
Okay. Sampritha, just the way we did it last time, you will be reading out your case within 5 minutes or so. And once you're done with that, then we'll start from your slide to a Viva session. Okay.
Yes, yes, sir.
Okay. For you and also for others who probably do not know, there's a scoring system, and the scoring system is going to be out of 50 marks. There are 5 segments that I've mentioned last time. And at the end of the series, the team that gets the highest is going to win this one. So yeah, there will be 50 points that will be awarded. And once you're ready, just share the screen, please.
Yes, sir.
The scoring parameters are going to be 10 marks for history, 10 for examination, 10 for management and understanding of the topic, 10 for communication. You cannot be fumbling honestly. And then the last 10 are going to be for higher order thinking. Those are those questions that I will probably expect from a PG person to answer on an average. But if someone from undergraduation is answering them, then that is going to be excellent, as they call it in the exam, as those gold medal questions or those questions which fetch you those brownie points. So that is going to be the last aspect, and cumulative of 50 points, 50 marks. So let us begin.
Hi, so good evening, everyone. I'm Sampritha, and I have Hemanth here with me. We're going to be presenting on a case of hypertensive
Could
disorders
you
in
switch on
pregnancy.
your slideshow so that the screen will be completely visible?
Actually, I have switched it on.
Acha, have you? Okay.
Is it seen?
It is not visible, but okay, that's fine, I guess. We can just get ahead if you are able to move your slides
Uh,
around. That's fine.
is it okay if we join from another device and then
No,
share
that's
it
fine. You just
so that will
continue now. Just continue. That's fine.
okay.
Begin.
So our patient is a 23-year-old primary gravida mother hailing from Bethamangala, Kolar, Karnataka. She's a homemaker by occupation, and she's of 23 years of age and from a lower middle class family according to the BG Prasad modified BG Prasad classification. It was a booked and immunized case. Her last menstrual period was on 3rd December 2024, and her estimated delivery date was calculated to be 10th September 2025. She was admitted on the 30th of June 2025, and she was examined on the same day. So she was actually referred from the Mangla Primary Healthcare Center. She was a primary gravida mother with 28 weeks of amenorrhea, and she had 2 episodes of convulsions since that morning. So we'll go more into the history. The history of presenting illness. So it was a 23-year-old primary gravida mother with 28 weeks of amenorrhea, referred from
Your
Mangla.
slides are not moving, Sampritha. Your slides are stuck on the third slide.
Okay.
Yeah, now it is
Yeah.
visible. Yeah.
So a 23-year-old primary gravida mother with 28 weeks of amenorrhea. She was referred from Mangla PHC in view of antepartum eclampsia, and she came with history of 2 episodes of convulsion. The first episode was at home at 5:30 a.m. on the same day, which was of GTCS type, and associated with frothing from the mouth, uprolling of the eyes, and tongue biting. The second episode was on the way to the PHC at 6:30 a.m. on the same day, of GTCS type associated with frothing from the mouth and uprolling of the eyes and tongue biting. The patient had elevated blood pressure reading when checked at the PHC of 160 by 100 mmHg. The PHC did not start with any antihypertensive. She also had a history of headache since 2 days. Coming to the negative history, there was no history of nausea, vomiting, epigastric pain, or blurring of the vision, and there was no history of pain in the abdomen, leaked PV, and bleeding PV. No previous history of fever, cough, cold, blood transfusion, or iron sucrose infusion in the past. No history of swelling of the limbs or undue weight gain, and there was no history of diminished urine output or diminished fetal movements, and no history of giddiness. So coming to the history of the pregnancy. So in the first trimester, the baby was conceived spontaneously. The pregnancy was confirmed by UPT in the 8th week of the pregnancy. The dating scan was done and was found to be normal. There was no history of morning sickness, hyperemesis, fever with rashes, or radiation exposure, bleeding PV, or leaked PV. The mother was started with iron folic acid tablets. There was also no history of any pain in abdomen, burning micturition, increased frequency of micturition. VDRL, HBsAg, HIV tests were done. They were all negative. And the HB estimation was done. GCT was done. HbA1c was done. And they were all within normal range. Blood grouping and RH typing was also done. In the second trimester, quickening was felt at 20 weeks. IFA tablets, that's the iron folic acid tablets, were continued. 2 doses of the TG injection were given to the mother. Anomaly scan was done and was also found to be normal. Calcium tablets were also started. GCT was again done and it was found to be normal. There was no history of bleeding PV, leaked PV, or pain abdomen, headache, dizziness, or there's no other history of blurring of vision or pedal edema or any excessive vomiting. So finally, in the third trimester, the patient came with the above complaints, that is the 2 episodes of convulsion and the headache since 2 days. Fetal movements were still perceived. The growth scan was done and it was found to be normal. There was also no other history of leaked PV or bleeding PV in the third trimester. So coming to the menstrual and marital history, the mother had regular menstrual cycles with a frequency of 28 days, and each cycle lasted for up to 3 to 5 days. There was a moderate amount of blood loss, and there was no history of dysmenorrhea. Like I've mentioned, the last menstrual period was on 3rd December 2024, and she achieved the age of menarche was 15 years old. There was also 1 year of marital life, and it was a non-consanguineous marriage, and there was no history of use of contraceptions. So she had, coming to the past history, she had no significant past medical or surgical histories. She was not a known case of diabetes or heart disease or thyroid, epilepsy or hypertension or bronchial asthma or tuberculosis. And she has no history of any allergy or any blood transfusions in the past, and no past surgeries as well. There was also no significant family or personal history. There was no history of the comorbidities like diabetes and hypertension in the family, and there was no history of twin pregnancy in the family or any other congenital, genetic, or hereditary disorders. And there was no history of preeclampsia in the mother or siblings. And the mother had no history of drug abuse or smoking or alcohol consumption. Her sleep was adequate and appetite was normal. She had a mixed diet, and the bowel and bladder movements were regular.
So coming to the examination part, so first we'll start with general physical examination. So patient was conscious, cooperative, and oriented to time, place, and person. where we measured height 159 centimeters, where the patient was moderately built and weight was 64 kgs and the BMI was normal. So her pre-pregnancy weight was 59 kgs and the total weight gain in the pregnancy was 5 kgs, which normally was between 9 to 10, but is
Hemant, you can skip the negative history part. I mean, the negative examination, all those normal things. You can just tell that the pulse was normal and everything, so that will help us proceed.
okay. So blood pressure was found to be 120 by 70 mm mercury, where measured at right arm and sitting position, and then respiratory rate was 16 and thoraco-abdominal type. There is no pylorictus. And the head-to-toe examination, where there is no injury marks on the scalp and there is no facial puffiness. And then only positive thing was oral mucosa was moist and the tongue bite marks were present. And then the systemic examination was normal. And then coming to the obstetric examination, where will inspection, where abdomen was uniformly distended and longitudinal, and all quadrants moving well with respiration, and the umbilicus is centrally placed and everted, and linea nigra is present and stria gravidum are present. There is no scars and sinuses, no dilated veins, and all hernial orifices are intact. So coming to the palpation, all inspectory findings are confirmed. There is no local rise in temperature and tenderness, and height of the uterus was corresponding to the 28 weeks of pregnancy. The fundal height is 27 centimeters. So coming to the Leposch-Meunier grip, the fundal grip, which is broad, soft, and bulky, non-palatable part is felt. Hence, breech is occupying the fundus. And then the lateral grip, smooth, curved, and hard, uniform, resistant, felt on the right side, indicating the back of the fetus. Multiple small nodules felt on the left side, indication the limb of the fetus. And then first pelvic grip, hard, round, palatable part of the limb, and then and the estimated fetal weight is measured by the Johnson's formula, and it comes to 2.325 kgs, and then lies longitudinal, and then fetal and auscultation, fetal heart rate is 146 beats per minute. In per vaginal examination, cervix was 1 centimeter dilated, and minimal effacement is present, and membranes are intact. And presentation part is cephalic, and station was -2. So summary: a primary gravida mother with 28 weeks of amenorrhea named Mr. M, age 23 years, working as an homemaker of lower middle class, who was booked and immunized with the last menstrual period on the 3rd December, and expected delivery date was 10/9/2025. Came with two episodes of convulsion. Sorry for the mistake. And she had a history of headache and since 2 days, and BP was rise like 160 by 100 mm mercury, were measured at the PHC, and the tongue bite marks were present. Height of the uterus corresponds with the period of gestation. Uterus was not contracting. Fetus was in cephalic presentation, and the fetal heart rate was 146 beats per minute. Provisional diagnosis. So, Mr. A primary gravida, 23 years old primary gravida with 28 weeks of amenorrhea, with estimated date 10/9/2025, with antepartum eclampsia, with single live fetus in cephalic presentation.
So the following investigations were done. The only positive
Investigations are fine. Investigations are fine. The reason I'm stopping you at investigations is in your normal routine exams, especially in most of the states, they do not give you the file.
Yeah.
So it is like everything without the file. So I'll ask you if it is required. Mostly we won't take it in our consideration because most of the students are not going to be given the file.
Yeah.
Okay. So we'll just keep it to a provisional diagnosis. By the way, Hemanth, this is the first time that I'm having a case wherein a male has gotten a preeclampsia, since you said Mr. M in your provisional diagnosis. Very nice.
Mrs. M, sorry.
So yeah, very well presented. The case history and the examination was kind of impeccable. I liked it. Could you just go to your first slide now to the demographic details?
Yes. Yeah.
Okay, fine. Now over here in the demographic details, could you tell me of all the things that you have written, what is important in terms of your history, in terms of your patient who has preeclampsia or eclampsia, whatever?
So the first thing that is important in this slide specifically will be the socio-economic class. They're of a lower middle class, and actually their living conditions. She's according to the history that we have taken, she did have a poor hygiene. So
Okay.
we would say,
Hygiene. Does hygiene have anything to do with preeclampsia?
like she had not specifically, but she did have she was from the lower middle class, so she was
So, sir, mainly the age is important,
Yeah, very good, very good. Good.
where she is like primary gravida.
Okay, good, very good. So
Then,
age and primary gravida. Could you tell me what is the correlation of age and preeclampsia? Where is it more common? Is your patient in that high risk category?
sir, yeah, she is in the high risk gravity, where primary gravidas are like more high
Okay,
risk.
primary gravida. But in terms of her age, is that age a high risk age?
Mm,
actually age less, like teenage pregnancy is a more high risk
Yeah,
compared to
very good. Very
pregnancy.
good. So teenage pregnancy is something that is much more common. Teenage and the other extreme, that is more than 35,
Old
40
age.
years of age. So yeah, both these extremes of ages. Okay, so primary gravida. Is it necessarily primary gravida? Can a female who is gravida to para 1 living one have the same risk as much as a primary gravida to have preeclampsia? Is there some clause for it?
same as
I the risk is the same, but the risk will increase if there's probably in her previous pregnancy, if she had had a preeclampsia or hypertension in the previous pregnancy,
Okay. I'll
then the
just
risk might
modify my
increase.
question. I meant if there is a female, you have two females. One is a primary, the other one is a para one, gravida to para one living one. Can they
Yes,
both have the same risk? And if yes, then what is the reason that they will have the same risk? Do not look into consideration the other factors, just
sir,
the age part,
sir, in
parity
primary
part.
one, primary one, like primary gravida, where you can find out the high risk in the first trimester, and you can give aspirin, and you can just
No, no,
like
no, no, no. The
separate
point that I'm making here is that actually, that if there is a female who is also a gravida to para one living one, she technically will have the same risk as much as a primary gravida if it's been more than 10 years since her last pregnancy. So, if there is a large interconceptional age, large interconceptional period that has elapsed between both the pregnancies, if it is more than 10 years, then the body has already forgotten what the paternal antigen looks like. So the risk is again going to be high. It is as much as she is as good as a primary gravida if it has been more than 10 years since the last pregnancy.
yes,
Okay. So it doesn't matter if it is anything, even if it is an abortion, there should be absolutely no pregnancy, not even an abortion, not even an ectopic in those 10 years, then the risk again increases. Okay.
yes, yes, sir.
Okay. So, okay, your age is one thing. She doesn't technically fall in the category of high
High
risk.
risk.
Primary gravida, very good. Could you tell me why primary gravida? Why primary gravida as a risk factor?
Uh,
very, very.
So there is one immunological cause where the maternal system is first is like it's exposed to the fetal antigens for the first time, so there could be improper tolerance.
Excellent. Very good answer. That female, not the fetal, I would rather say the paternal antigen. The baby is 50%
Yeah.
father. So she is exposed to that paternal antigen for the first time in her life, which is
Yes,
why her risk is going to be high. So if she marries some other person or if she has a child with another person, then that pregnancy is also going to be technically like a primary gravida because now she's exposed to that father's antigen for the first time.
yes,
You get it? So the
yes,
risk only reduces after first pregnancy if she is having child with the same father, if the paternal antigen is the same across
yes,
all pregnancies. We get a lot of patients who have remarried, who have gotten married because of some problem, demise or divorce or anything with the previous partner. That again increases the risk as much as a primary gravida. So it is not about the primary gravida, it is about the exposure to the paternal antigen that is making the difference over here. Okay?
yes, sir.
Yeah. The next part that you mentioned, primary gravida, gestational age, very beautiful point that you have mentioned over here. She's a 28 weeks female who has now had an episode of eclampsia. Do you think it is an ideal age or is it too early?
So actually, 28. Like I didn't understand. Ideal. Sorry.
When do you usually get patients? When do usually patients get severe preeclampsia, eclampsia? Is it this early, 28 weeks?
Actually, yes. Like it usually eclampsia is the most common time for eclampsia will be the third trimester. Actually,
Yeah, very good. So the third trimester has just started in your patient. So do you see it
yes.
in the late third trimester or in the early third trimester? Usually.
Usually it'll be in early time.
No, it is in
Mm.
fact going to be in the late. This is actually a rare case of early severe preeclampsia. This
Yes.
female, you do not usually get, you do see cases, but it is not that common to see patients having 28 weeks preeclampsia, severe preeclampsia, not just preeclampsia, severe preeclampsia. Now that you
Mm.
have a female who has such an early onset, do you want to look at some other risk factor? Do you want to probably consider some reason why she has gotten this at this early?
Yes, sir. We probably have to go into the reason, like especially to prevent this in the future pregnancies as
Okay, so what can be one of the reasons? Just give me one commonest reason.
well. Um,
Excellent answer, Sankavi.
Sampritha.
They
No,
always.
no, Sankavi, someone has answered it in the comments. The answer is, do you know what is the criteria that we use for diagnosis of Apla syndrome? In that criteria, you have, in Apla syndrome, by the way, you have something that shows, or there is, do you know the criteria for Apla syndrome diagnosis?
Yes, sir. There is a increased. Sorry, there is increased. Yeah.
There is a
Um,
clinical criteria and there is a laboratory criteria. So in your clinical criteria, you have normal, that is non-pregnant criteria and pregnancy criteria. So in your pregnancy criteria, one of the criteria is a bad pregnancy outcome because of abruptio or severe preeclampsia or eclampsia. Basically, any placental disease that has occurred at an earlier gestation that required termination. She technically fits into that non-pregnant into that pregnancy clinical criteria, and hence, after her pregnancy is done, I would want to at least have a look at her APLA profile. Very likely that she can have APLA profile, APLA positive status. But I would again come to the same thing. APLA positive, how is it going to lead to preeclampsia? Heyman,
Sir,
uh,
Sampratha?
so, sir, actually, APLA is like it's the fatty liver. Is it?
No, that is acute fatty
No,
liver
it's
of pregnancy.
antiphospholipid antibody syndrome. So it is. It's an autoimmune disorder. So, like, there can be thrombosis in the APLA syndrome, and because of that, like, probably, like, not sure exactly.
No, something else. There are a few people who are answering that in the comments. I am sharing my screen, by the way. I'll just switch on my own notepad.
So, like in APLA, there is it's a pro-inflammatory state, so the placental development can be affected.
Okay, so the thing is, in APLA syndrome, what happens is you have antibodies against phospholipids. Now,
Yeah.
phospholipids are present in every single cell membrane and cell membranes that are present throughout your body. Because we have read about phospholipid bilayer in our 12th standard and our first year of MBBS in biochemistry. There is something called as phospholipid bilayer, which is present in every cell membrane. So those antibodies are going to go and attack them. What does this lead to is it not only attacks all the organs, but most importantly, it attacks the endothelium of the vessel. Now, because of this attacking of endothelium across the body, it leads to endothelial dysfunction. Whenever there is endothelial dysfunction or endothelial damage, there are going to be platelet plugs that are going to be formed. Correct?
Yes. Yes, sir.
So whenever there are those platelet plugs that are being formed, those platelet plugs, especially in my placenta, are going to cause placental ischemia because the blood supply is getting blocked in those spiral arterioles and everything. So this ischemia is going to release a few hypoxia wala factors from the placenta, and a few of those factors includes your soluble FMS like tyrosine kinase and your soluble endoglyn. These are those two factors that are responsible for the pathogenesis of preeclampsia, which is why any thrombophilia, especially APLA syndrome, which damages your endothelium of your vessels, of your small vessels, arterioles, and the spiral arterioles of your placenta, is going to lead to placental ischemia, and that will eventually lead to the development of preeclampsia. And hence, you have these bad outcomes, early bad outcomes that happen in these women, because Aplar syndrome is something that you have since your first day of pregnancy. So the moment your placenta starts forming at around 8 to 10 weeks of gestation, in the first day itself, the placenta is not having a great vascular supply. So whenever this is happening, it ensures that your placenta is so poorly developed that eventually at an early gestation, as early as 24, 25 weeks as well, you can get severe preeclampsia. Okay?
Yes, sir.
Okay. So now that we are talking about this, could you tell me what is the earliest, now let alone Aplar syndrome, what is the earliest that you can have preeclampsia?
So, preeclampsia, to diagnose it, you need to be at least, the mother needs to be at least 20 weeks of
Are you
gestation.
sure about 20 weeks? Is that a criteria? Why does preeclampsia happen?
Sir,
A few people are saying first trimester. Is that right? Pushpa just said first trimester. Is it correct? Can you have preeclampsia in first trimester?
So,
preeclampsia causes because of the inadequate trophoblastic invasion.
Yes, very good. Trophoblastic invasion is going to cause a defective trophoblastic invasion is going to cause preeclampsia. Very good. So when does this trophoblastic invasion of wave of invasion happen?
so there are two waves. One is in the first trimester. It will invade the or up to the decidual layer, and in the
Very
second
good.
trimester, it will go to the myometrial layer. So,
Okay. So when is it done completely?
uh, so by then, like in the second trimester, it is completely
No.
invaded into
Which
the.
exact weeks of gestation is it done?
Um,
Hemant?
Yes, sir.
So the first wave is done by 12 weeks of gestation, and the second wave of invasion is done by 16 weeks of gestation.
16
weeks,
16
yes.
weeks.
Your second wave is important because you all know that the entire placenta is made only by 12 weeks. Between 8 to 12 weeks, it is still forming. So your major placenta wala jo modeling hai, remodeling hai, that is going to only happen between 12 to 16 weeks. Earlier, it is going to be part of it. Hence, your second wave of remodeling between 12 to 16 weeks is the most important wave, and that is why most cases of your preeclampsia are going to be diagnosed after 16 weeks. So, whenever you're asked what is the earliest that you can have severe preeclampsia or the diagnosis of preeclampsia, it is as early as 16 weeks. Okay, it is not 20, it is as early as 16 weeks. It is just that those cytokines, those soluble FMS like tyrosine kinase, soluble endoglin, they take some time in my body to form, to start acting, which is why we start getting those hypertensive episodes after 20, 24 weeks. Okay, but you can have it as early as 16 weeks of gestation. So now that we have spoken about preeclampsia, could you define what preeclampsia is? The first important question of the session.
So preeclampsia is defined as having a systolic BP reading of more than or equal to 140 mmHg and diastolic BP reading of more than or equal to 90 mmHg, or
Very
both,
good.
which is measured two times, which at least 4 hours apart.
Okay.
And it is accompanied with proteinuria.
Either,
Okay,
sir,
very good.
either proteinuria or end organ dysfunction.
End organ damage.
Okay. Will end organ damage be called as preeclampsia?
Yes,
Or
sir.
will it be called as severe preeclampsia? Is end organ
End
damage a
organ
part of
damage will be severe preeclampsia.
Okay, so in your preeclampsia, you do not mention target organ damage or end organ damage. It is a part of severe preeclampsia.
Yes.
Okay. So in your preeclampsia, as you mentioned, it is hypertension plus proteinuria. Correct. Its counterpart is chronic hypertension. What is chronic hypertension? Quickly tell me.
So in chronic hypertension, the mother would have signs of hypertension before the pregnancy, and it will persist for longer than 12 weeks postpartum.
Okay, very good. Now assume that you have a patient who is 8 weeks of gestation, just 8 weeks, and she has chronic hypertension. So my first question to you is, if this female has chronic hypertension, what are the various causes of chronic hypertension?
So chronic hypertension can either be due to any chronic renal diseases or any
Like,
endocrine disorder, like chronic renal disease, CKD.
Okay, fine. That's fine.
Or endocrine disorders like diabetes mellitus or pheochromocytoma or
Yeah,
thyrotoxic.
pheochromocytoma is a better answer. Diabetes is an indirect factor. Do not say diabetes as your first answer. Pheochromocytoma is very good. Anything else?
Or it can also be due to any connective tissue diseases like
Like SLE.
SLE.
Very good. Excellent answer. Love this answer. Anything else? Any blood test that you can do? Some B12 thing? Just a hint for you. Anything related to B12?
Megaloblastic anemia or
No, 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 no. Something related to B12 metabolism that leads to hypertension. That's your hint.
um,
Homocystinemia, hyperhomocystinemia.
Like
okay.
Yeah, that is one of the causes of your hypertension in pregnancy. So, okay. We have now mentioned that. Your second question is your same female, chronic hypertension at 8 weeks of gestation. You
Yes.
have that female who has proteinuria. Is it preeclampsia now, or is it heading towards preeclampsia?
Mm, I think it will be heading towards preeclampsia because, like,
Okay,
according to
but is
the
it preeclampsia? Would you call this preeclampsia?
no,
Why?
because like we have discussed like just previously in the pathophysiology. So the
Very
preeclampsia is
good.
when the
Very
tropo.
good. So it is only once the placenta has formed. Your placenta is not yet formed at 8 weeks of gestation. So your chronic hypertension has probably led to hypertensive nephropathy prior to pregnancy that has resulted in this proteinuria. Or maybe there is some other cause of proteinuria. There might be a urinary tract infection or some other disorder of the kidneys, but not your pregnancy causing that preeclampsia wala proteinuria. This is not your preeclampsia wala proteinuria. This is a proteinuria of some other origin, some other cause. So remember this, if you have a patient with proteinuria in the first trimester, remember that it is nephropathy because of some other cause. Probably it is CKD, and that CKD or chronic renal disease or chronic kidney disease, whatever you call it, that has led to the hypertension as well as proteinuria. That is probably the cause of it. So you will have to do a KUB, USG, KUB and everything, kidney urinary bladder and everything to look at some other cause of proteinuria. Okay, great answers. Next slide.
Geez.
Okay, so she was referred 2 episodes of convulsions since morning. Okay, so could you tell me what are going to be those? You have, I think, discussed it in the next slide. I'll ask there itself. Could you go to the next slide? Okay, so uprolling frothing, it is GTCS type. Great. Now, your first question: what is the cause of seizure or convulsion in preeclampsia?
So, sir, there are cerebral vessels. So, because there is anoxia in the spasm of the cerebral vessels, basically, and because of that, the vascular resistance will increase, and there is anoxia. There is fall in the oxygen consumption in the brain because
Okay,
of
one
that.
of the reasons. Very
And
good.
then there could also be cerebral edema, which will cause any
Excellent. That is the answer that I wanted. Could you tell me what is the name of that edema? What is it called as?
uh,
That's fine. You are answering really, really well. It is called as vasogenic edema. Vasogenic because the cause of that edema is because it has come out from the vessels and it is not because of some infection or anything. So vasogenic edema, it is called as vasogenic. Okay.
okay.
So what other causes of convulsion in a female in preeclampsia? You mentioned two important causes. Anything else that you can think of?
Or maybe there could either be excessive release of excitatory neurotransmitters like glutamate or
That is actually the cause of any seizure. But why in severe preeclampsia? Something more. Imagine your patient has a BP of 220 systolic. What will happen?
and cerebral dysrhythmia, which
No, you have 220 systolic blood pressure. There are probably small vessels in the brain that are going to bleed. You will have a hemorrhagic stroke, and your
okay.
hemorrhage is going to cause an episode of convulsion. Although it will not be a GTCS type, it is going to be a focal seizure because that bleeding is probably going to be in one region of the brain. You can also have a GTCS type of seizure, but that is one of the causes, hemorrhagic stroke. Okay, so
Yes.
that is also the reason why every single time a female has had convulsion, all the classic textbooks say that if she has had convulsion because of eclampsia, That is it, just treat her with magnesium sulfate and do nothing. Absolutely wrong. I do not believe that is the right thing. Every time you have had a female who is or who has had a convulsion, after she's stabilized, after she has delivered, go and do an MRI of the brain. Either do an MRI or a CT scan to determine whether it was only and only because of that vasogenic edema, or is there some bleed that has happened inside, because the treatment is going to be different in both of them. Got it?
Yes.
Okay. So your patient had a GTCS type of seizure at 5:30 a.m. in the morning with frothing from the mouth, uprolling of eyes, tongue biting, and it is associated, actually, it is written twice. Okay. So she had a blood pressure, elevated blood pressure of 160/100. Okay. So what is 160/100? Fine. Could you tell me what is delta hypertension?
So it's a psychological, like when the patient.
That is white collar hypertension.
So,
Yeah.
delta hypertension is the difference between the systolic and the diastolic
That
pressure.
is your pulse pressure. So delta matlab difference. Now you know the reason why normal BP is said to be 120/80 is that they studied lakhs and lakhs of people, and they realized that at 120/80 BP they are not having any target organ damage. But it was a statistically derived value. For a few people who are lean and thin, 100/60 is going to be the normal. For a few people, 130/90 is going to be normal for hefty, big, large people. 120/80 is a statistically derived value. So 140/90, which used to be hypertension for a female with a normal BP of 120/80, instead for a female who has always had a BP of 100/60 as a normal BP for her, even a BP at 130/90 may give rise to eclampsia or severe preeclampsia or the signs of target organ damage. This is called as delta hypertension. These differences, these fine differences. So only because your patient has a BP of, let's say, 130/90, do not discount the fact that she may have had preeclampsia or severe preeclampsia whenever she convulses. Always look at other causes as well. Always look at these factors as well. The build of the female, if she's hefty or if she's very petite, very small, and that is where your delta hypertension as a concept comes into foreplay. Anyway, that is okay. You are done with it. Your patient has a BP of 160/100. What is your target BP for this female?
So it should reach 140/90 mmHg.
Okay. Would you want to keep her BP at 120/80?
The target BP will be 140/90, sir.
Okay, it is going to be target BP is going to be 140/90. That's a very good answer. Could you just tell me the reason? Now, this is a higher order thinking skill. Could you tell me why 120/80 is not going to be ideal for this female?
The hypotension.
Do not look at those answers because they are completely wrong. Most of those answers are wrong. So don't think. Just think in your direction. Your patient is an antenatal female. She had a BP of, let's say, 180, 120, 160, 110, and you take her BP down to 120/80. What will happen?
Sir, it could, like, the uteroplacental perfusion could be
Very good. Excellent. Your body is now auto-regulated to have a BP of 160, 100 or 180, 120 or whatever. If you're going to suddenly bring it down to 120, it is like causing hypotension. And your body is not going to get time to adjust because you're doing it artificially by medicines. It is not happening naturally, and that is going to lead to perfusion defect. The perfusion of the baby is going to be a problem, and hence you will never try to achieve 120/80. 120/80 is the target BP for someone who had a BP of 140/90. Whereas for someone with anything more than 140/90, the target BP is going to be 140/90. For anybody with a BP more than 160/110, for them the target BP is going to be 160/110. You maintain the BP at these targets, and then 2 to 3 hours later, you bring it down to a further lower target until it reaches 140/90. 140/90 is where you end it. Uske aage kuch mat karo. Got it?
yes.
Okay. So your patient had a GTCS. Now imagine that your patient was in your ward. She was a severe preeclamptic, but she had not had eclampsia. But now in front of you, you are an ObGy resident, and she has had an episode of convulsion in front of you. What do you do next?
For stabilizing the patient.
Okay, what all do you mean by stabilizing?
Like put the patient in the left recumbent position,
Okay.
so that and then next we'll check for the airway, breathing and circulation,
Okay. Very good.
and then like we'll put a mouthpiece for
Very good. Mouth gag. Oropharyngeal gag is a better word.
okay, mouth gag.
Why do you put it?
Sir, to prevent the tongue bites.
Very good. Tongue bite, or from the tongue to fall behind on itself.
Yeah.
Very good. What's next?
And then we'll give in like magnesium sulfate regimen therapy, like anticonvulsant therapy.
Okay. Anything before that? Magnesium sulfate ke pehle your female had just come to you and she collapsed. She had a convulsion in front of you. Would you do something more as well to her?
So we'll just watch the seizures, like how long it's lasts or type of the movement.
Okay. Okay. You mentioned about ABC. ABC में क्या क्या करोगे? What all will you do?
Like we'll check for the like is she breathing or not? Like
Okay, you will auscultate her chest. You will
yeah.
see whether the air entry in both the lungs is equal. Next, you will go ahead and look for her breathing if it is excessive or less. And then for circulation, the thing that I was asking you is circulation, mein what will you do?
Like pulse, check for the central pulse, carotid.
No, circulation is not that. You would want to secure a wide bore axis. Two wide bore needles are going to be attached in your both the hands. Okay. Okay. So next, now you will go ahead with magnesium sulfate.
Yes, sir.
Okay. Anything else also that you will give her? Her BP is 160, 100. Will you do anything?
Hypertensive drugs will give, sir.
Okay. Which, how would you give it? Orally or
IV.
intravenously? IV.
Intravenous.
Very good. Why?
Sir, fast acting.
Is it because of that or because of some other reason?
And because the patient is in convulsions and then you can't.
Yeah, very good. The patient is in post-ictal phase. Post-ictal phase में confusion, altered sensorium, she may aspirate the water or the drug that you're giving, which is why we have to give it IV. Okay, what is the maximum dose of labetalol that you can give in a day?
The maximum dose.
Sampritha, would you want to attempt?
Sir, 2,400 mg like per day. You should divide it
Okay,
into.
that is the oral dose. Although we do not go that high, we restrict ourselves to 1200 milligrams. 2400 is very theoretical. What about IV? Your answer is correct, by the way. Your answer of 2400 is correct, but practically we do not go that high. We only give 1200 and then we add some other alternative antihypertensive. Okay. What about the IV dose maximum?
300 mg.
Yeah, it is 300. Earlier it used to be 220, but now it is 300. A few people even say 320. That is okay. But 300 is the new one. It is not 220. How do you give labetalol? IV labetalol?
IV bolus.
Bolus. Okay, but how do you give it? Is there a technique?
Like, initially, we'll give 20 milligrams over 2 minutes.
Okay. Okay. Over 2 minutes. Okay. I would rather make it 10 minutes. A
Okay,
little slower.
okay, sir. And
Yeah,
then
over 5
there'll be an follow-up doses like 20 to 80 milligrams every 10 to 15 minutes as
Okay,
needed.
till you reach the maximum dose. So do you monitor anything while giving this?
So monitor the BP hourly.
BP hourly. Oh my God. Then how are you going to be giving it every 15 minutes?
Sorry, sir, every 10.
Okay. Apart from that, while infusing, because of Dale reversal phenomena, you have to also keep a track of her pulse.
Pulse.
If her pulse goes too low, you have to stop giving it immediately. So you have to have a look at her pulse. Remember that. And if the female goes into severe hypotension, there can be reflex tachycardia. You have to be looking at that as well. Okay. What is labetalol? What is a class of drug?
Beta blocker.
Ah, I knew it. This is where everyone loses their marks.
It's
Sampritha, do you want to attempt?
alpha. It's a mixed. It's like
Yeah,
alpha.
it is alpha. Do not attempt a beta blocker as your answer because beta blockers that we give, metoprolol, are all cardioselective. You want something to act on your vessels and not your heart. Hence, it is alpha plus beta non-selective blocker. Okay. Any
Yes.
alternative drugs?
Hydralazine.
Oh, hydralazine is your second line drug. Sampritha, any other answer? Think before you answer.
Methyl
You
dopa.
go to your ward, you are never going to see anyone give hydralazine today.
Yes, sir. Methyl dopa will.
Methyl dopa, oh my god, methyl dopa. Hemant, where are you presenting from? Is the year 1995?
Yeah, no, sorry.
Acha, okay. Sampritha, any other answer?
So nifedipine you can give.
Yeah, nifedipine, very good. What is the nifedipine is a good answer. Everyone who's answering Nicardia, remember that Nicardia is a brand name. We give nifedipine. Do not answer Nicardia in your exams. It is nifedipine. You get nifedipine in two forms for those who are asking, those who are answering. Nifedipine, when it is given as a stat drug for tocolysis, stat is basically the one that will have immediate release, is going to be given in the form of normal nifedipine or what we also call as capsule depin. Whereas the Nicardia that you're seeing, Nicardia is made from two words, nifedipine and retard. So Nicardia, Nicard. That is an action that is a slow release, sustained release, or extended release action that will help to monitor or maintain your BP for 8 to 12 hours. That is what you give for antihypertensive control. So nifedipine sustained release is the answer that you will give. If you want an acute blood pressure control, then you give the capsule that is fast release. But for your overall maintenance of your blood pressure, you only give the Nicardia form of it, that is the retard form of it. Okay, what is the maximum dose that you can give in a day, Nicardia? Okay,
120 milligram.
yeah, 120 milligram. Very good. The answer is 120. So very easy way to remember is Labet ka oral is 1200, 1200, and nifedipine ka it is 120. That's it. 120 maximum to be given in a day. Any precaution to be taken?
Um,
Very simple. The patient should ensure that they should not just keep it in their mouth for a long time before they drink water. कुछ लोग क्या करते हैं, they just keep the capsule in the mouth, then they drink water after a minute. No, it will immediately start dissolving and lead to sudden hypotension. Sudden hypotension that can lead to them collapsing as well as fetal demise. So that is the only precaution that you have to take with nifedipine. It is having very strong action if taken sublingually or if kept in the mouth for too long. Okay.
yes.
So now, um, okay, so just go to the next slide. By the way, coming back to your question, hydralazine and methyl dopa, do we give them anymore and why not?
So methyl dopa is a centrally acting drug. So
Okay, what will that do?
uh,
The biggest reason why methyl dopa, which used to be the drug of choice at one point of time, got out of action was first of all hypotension, and secondly, it would lead to hemolytic anemia. It would turn Coombs test positive, and that hemolytic anemia was not an acceptable, what do I say, acceptable side effect. More so because HELP syndrome में hemolysis anyway हो रहा है, and you do not want more hemolysis to happen because of a drug that you're giving to treat hypertension, which is why it went out of complete choice. It is no longer chosen. Hydralazine, the only problem is it's a good drug, but the problem is, irrespective of the dose, it leads to hypotension, and that hypotension is going to lead to immediate fetal bradycardia or fetal distress, which is why we prefer to not give it anymore. Okay. Next slide. Okay. You have mentioned all other things. Could you tell me a few more risk factors for preeclampsia apart from the ones that you have already mentioned? Sampritha, Hemant, am I audible? Hemant, Sampritha, am I audible?
sir, can you hear us?
Yeah, you are audible. I hope the internet is not an issue because you'll have to recharge your internet if you have not recharged it already.
No.
Anyway, could you tell me the risk factors?
Obesity.
Okay, obesity, very good. Obesity will lead to chronic hypertension, which itself is a risk factor. Okay, anything else?
An history of previous preeclampsia and preostrel.
Okay, very good. Next,
And then family history.
family
There,
history. Okay,
and then, as you said, it's a pregnancy with a new partner.
very good. New partner, new father, new
New father,
paternity.
yeah, paternity agent exposure. And
Next,
then multiple pregnancy.
okay, why multiple pregnancy?
Um,
Very simple. Larger the
More
placental mass,
Pregnancy,
placenta, more
yeah,
placenta.
more will I more problem.
Mm.
So the larger the placental mass, the more the risk of severe preeclampsia and early preeclampsia. Okay, what else?
Mm.
Um, any lifestyle, like smoking, poor diet.
Very good. Smoking. Okay. Smoking. That's a very nice point that you have mentioned. Can someone in the audience tell me, is smoking a risk factor? Before that, I would want you to proceed with some other risk factors as well.
Mm, I think that's like we're not sure of more, sir.
ART, assisted
Oh,
reproductive technique.
assistant. Yeah.
That's
Yeah, assisted reproductive techniques. A very beautiful point. If you're able to answer this, I'm going to be giving you excellent marks for the higher order thinking skill. Why should ART lead to preeclampsia?
Uh, so like so in like natural conception, like because the embryo is like the uterus would be hormonally like since the it's a spontaneous conception, it
You're
like
very close. You're very close. Why? You're coming very close.
uh,
You have one hand on the answer.
uh,
Mm.
like the the synchrony between the embryo, like the placental formation maybe like
Very close. Very, very close. So there are multiple reasons why in ART there is an increased risk of preeclampsia. First of all, in ART there is often multiple pregnancies, so a larger placental mass. Secondly, you often may have a donor ovum as well as a donor sperm. So what is usually only 50% paternal antigen that is foreign, now you have 100%. Even the donor egg is also a foreign body, foreign antigen for that female. So 100%, the entire fetus is probably something that the baby, that the mother's body is not used to. So another reason. And lastly, a very significant reason is that in your ART pregnancies, you do not have a corpus luteum because you are artificially hormonally making that pregnancy happen. You are giving multiple injections, and hence a corpus luteum is absent. A corpus luteum releases something called as relaxin. This relaxin is very important for the development of those spiral arterioles and its dilatation. The absence of this relaxin is going to ensure that these arterioles are constricted, and that constriction is going to increase the risk of placental hypoxia and then preeclampsia. Got it?
yes sir.
Okay. Placenta, smoking is protective, by the way. That's a correct answer given by the audience. Smoking is protective because the carbon monoxide and the nicotine that is produced by the smoking is going to, in fact, inhibit the anti-angiogenic factors like SFLT2 and your soluble FMStic like tyrosine kinase and your soluble endoglin. So all these anti-angiogenic factors are going to be instead inhibited. It is very similar to why smoking is protective for that the nicotine is going to inhibit aromatase. Aromatase is the enzyme that produces estrogen from testosterone, and once your estrogen is inhibited, your endometrial hyperplasia will not happen, and hence smoking will protect you, in fact, against endometrial cancer. So it will give you bladder cancer or lung carcinoma as a gift, but it will protect your uterus and your pregnancy. Got it?
Yes sir.
Okay. Continue.
Yes.
Yeah, continue. Yeah, continue. You can read it.
So we'll read through the slides again, sir.
Okay, there is nothing in this. Okay, go to the examination now.
So next slide, or should
Okay,
we?
general examination, no. Wait here, I'm just reading it. Okay. So you have already mentioned that obesity is one of the risk factors for preeclampsia. That is fine. Pulse, okay. Oriented, okay. So she's conscious, cooperative, and well-oriented. So she's not in her post-ictal phase, right?
Yes,
She's
sir.
not in her post-ictal confusion or altered sensorium. Okay, that is good. Next slide. By the way, this BMI that you have taken, never take a BMI during pregnancy. In your first line, that is not required. You only give a pre-pregnancy BMI.
Oh, okay, sir.
Okay. What is the ideal weight gain? Do you think this weight gain for her has been ideal?
So ideal is 9 to 10 kg.
9 to 10. In a preeclamptic female, is it going to be more or less than average?
Sir, if if the mother will have edema or swelling of the
Yeah,
lymph,
very
then
good. So it is going to lead to an increase in weight. Very good. Good answer. Okay. Apart from that, nothing. Next slide. Blood pressure. Okay. Very good. So how do you measure blood pressure in pregnancy?
like sir, either in a sitting position, uh,
Okay.
over the left arm, so the cuff should wrap around at least one
Left
point.
arm. Left arm. That is criminal to
Sorry,
measure blood pressure.
right arm.
Yeah, you do not change the arm. The arm remains the same. All the studies have been done in right arm only. Okay, next. Next as in what do you do next? Then you measure the BP. Okay, what is the other position? Left lateral position. Why do you do this? Why left lateral position or a sitting position and not a normal supine position for measuring BP?
Uh, so
Yes,
the
Hemanth is saying
uterus,
something.
Like to avoid supine hypotension syndrome. Like
Yeah, what is supine hypotension syndrome?
like in the supine position, the gravity uterus compresses the inferior vena cava.
Okay, good. And that
It
will lead
increases
to,
the venous return.
yeah, so the preload is going to be reduced. And
Reduced.
that is going to lead to your reduction in the blood pressure. Okay, very good. So it is going to be falsely low. Also, because of your aortic compression as well, your blood perfusion to the baby is going to be affected. Hence, you never keep a female in a normal supine position in a third trimester, especially.
So
Okay. Okay, so this is one of them. Is there any test that you can do to predict preeclampsia in the first trimester while measuring the BP, which utilizes the principle of supine hypotension?
um,
Everyone is answering rollover test. What is your rollover test? Okay, so what it is now, whenever you are shifting a patient from left lateral position to your normal supine position, your BP should ideally fall, which is actually what is supine hypotension. But instead, if your blood pressure, especially your diastolic blood pressure, increases and the increase is by more than 20, it is an indicator of prediction of future preeclampsia. This is the rollover test. So basically, in your supine position, instead of hypotension, you get a higher BP than what it was in your left lateral position. So in fact, it is becoming supine hypertension. That is what is called as a rollover test. Okay.
yes.
So it is a predictor for preeclampsia. Do you know of any other tests or any other ways to predict preeclampsia in the first trimester so that you can start her on aspirin?
Um,
पप्पा कौन बोला है? अरे it is not पप्पा रे, it is PAP A.
PAP.
So what are the other ways of testing, or what are the other tests for the same?
urine plasma protein level, SFLT,
Yeah, very good. Very good. Plasma protein, not really, but predicting, not diagnosing, predicting. You were mentioning SFLT2. That is a very good answer. Very, very good answer. Good. What else?
Placental growth factor, page.
Okay. Placental growth factor. Good. Well answered. Is it going to be low or is it going to be high in preeclampsia?
Low. So,
Yeah, low. Very good. Any other factors? Any other tests?
Mhm.
सबसे important test.
urinary doctor.
Like s- sub no protein urine.
Hemant, you are correct. Answer it.
Uterine artery Doppler.
Uterine artery Doppler, or to be more specific, uterine artery pulsatility index, uterine artery PI. So if your first trimester, that is between 11 to 14 weeks when you do an NT&B scan, if your uterine artery PI is more than 2.4, it is going to be predictive of preeclampsia or fetal growth restriction in future. Similarly, if you're doing the same test between 20 to 24 weeks, then if your uterine artery PI is more than 1.4, then it is again going to be it is going to be predictive of preeclampsia. Similarly, there was someone who had asked, how do we predict that there can be late or early preeclampsia? On the basis of your level of SFLT2. If it is more than 110, then it is going to have, eventually the female is going to have early and severe preeclampsia. Whereas if the levels are just more than 85 and less than 110, then it is going to be late onset preeclampsia. So SFLT2 is a very important and a very good test that you can be doing. Apart from that, various other tests that we can talk. There are many that people have mentioned. There is something called as an ophthalmic artery Doppler that I've already discussed on my channel once. Ophthalmic artery Doppler, may you go and do an ultrasound of your ophthalmic artery by keeping the probe over your eyelid, upper eyelid, and you get to see a notching. And you measure E by A ratio. Not important, just remember ophthalmic artery Doppler, that is one thing. Apart from that, SFLT2, VEGF, all these things, all these parameters can be checked and the patient can be predicted of having preeclampsia. If the female is high risk, what do you do?
Low dose aspirin is given.
Okay, very good. Low dose aspirin. What is the low dose?
75 to 150.
Very good. It is actually 60 to 150. What we give is either 75 or 150. What is the ideal dose? Exact. Ideal कितना देना चाहिए? इंडिया में मिलता नहीं है वो. कितना है?
Ideal dose 180.
Yeah, वो जो आंसर बता रहे हैं वो सही है. It is 81.5. You do not get that dose in India. But the ideal exact low dose that you can give is 81.5. That is the ideal dose. How does aspirin prevent or delay preeclampsia?
Sir, so aspirin is it's an anticoagulant drug.
Then COX-2 inhibitor.
It is a COX-2 inhibitor. So
COX-1.
It is not a
works
COX-2 inhibitor. Aspirin is definitely not a COX-2 inhibitor. Aspirin is a non-selective COX inhibitor. Okay, so that is going to inhibit. Yes, आगे बोलो.
So, sir, because it's a COX inhibitor, it will modulate the thromboxane prostacyclin balance. So it will improve the placental perfusion, and it will reduce the
Very good, very
inflammation
good.
and
So thromboxane A2 is going to be reduced and prostacyclin, that is PGI2, is going to be increased.
increase.
That will lead to vasodilatation. Apart from that, it is also having an anti-platelet action, which will prevent the endothelial dysfunction के बाद the platelet plugs that we had mentioned that lead to damage to the spiral arterioles that we had mentioned, all the spiral arterial blockages, placental ischemia, even that is going to be prevented. So its anti-platelet action and its ability to reduce thromboxane A2 and increase prostacyclin is going to lead to its positive effect on pregnancy during risk of preeclampsia. The higher dose that we give for patients with rheumatoid arthritis and all are anti-inflammatory doses. Those are 300 and above. We do not give them in pregnancy. Why do we not give it in pregnancy? High dose.
Uh,
Higher dose technically should be a good thing. It will have even better action of antiplatelet, even better action of thromboxane A2 inhibition. But why not?
So, sir, a low dose aspirin, it selectively, it inhibits, it mainly acts on the thromboxane A2, and the prostacyclin is like, it's more preserved. But in the high doses, it will act equally on both the
And
cox.
inhibit both. Yes, something more than that, something a little more, something about the fetus.
Where it
So it may increase the risk of like hemorrhage in the.
Oh, अरे वो तो तुम लोग सबको देते हो. हाई डोज रूमेटॉइड आर्थराइटिस का पेशेंट रोज लेता है. रूमेटॉइड आर्थराइटिस या ऑस्टियोआर्थराइटिस का पेशेंट तो रोज लेता है. इट इज अ डेली थिंग फॉर देम. उनमें हिमरेज नहीं होता है. Yeah, that is the answer that everyone is just answering. There will be premature closure of ductus arteriosus. It is an NSAID after all. NSAIDs will lead to inhibition of prostaglandins. Prostaglandins are important for keeping the ductus arteriosus open in utero. So in utero, if there is a closure, that will lead to persistent pulmonary hypertension after delivery. The baby will have respiratory distress. Apart from that, also a very important thing, it will inhibit your renin-angiotensin cycle of the baby, and that will lead to oligohydramnios. Hence, you would not want to give those high doses. Got it?
Yes, sir.
Okay. Next, you have mentioned about no pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema. No edema is a little unlikely, but I'll give it to you. If you had edema in a patient with preeclampsia, what type of edema is it going to be?
So, like it will be a pathological edema
Okay,
because
good. Pathological edema. What is the difference? Pathological and physiological?
so physiological edema, it's mostly seen in the dependent parts of the body compared to the pathological
Hmm.
edema. So in
Good.
case of pregnancy, the edema is seen also in the morning time, and in case of physiological, it actually increases as the day passes, as more
Very good. Very
reactive,
good.
and that's the main difference.
Okay, good. So what is the cause of physiological edema in pregnancy?
So it is because of the increased plasma volume, so there's hemodilution in pregnancy. So that is one.
Something else. Hemodilution is the correct answer, but what about hemodilution? You are on the right track.
So because of that, the so hemodilution and the
Oncotic pressure,
will
very
decrease.
good. Oncotic pressure will reduce, and that will lead to uh, your pedal edema, bilateral pedal edema. Also, because your IVC is getting compressed, there is venous stasis. That venous stasis will also ensure that there is pushing out of all the fluid from the venous space into the interstitial space. Okay,
Yes, sir.
that's a good answer. Good. So, what about pathological edema? It is going to be on your non-dependent areas, like few examples.
So like there can be facial puffiness
Facial puffiness, yes. What else?
in like in the upper limbs.
Upper limbs, okay. What else? A very common organ where we see this edema, vulva. Your
Vulva.
vulva is going to have vulval edema as well. That can even, in fact, because of your vulva is often going to then rub against your medial side of the thigh, that can lead to epidermal peeling. Your epidermal peeling will lead to lacerations, ulcers over there, which will require dressing. So, vulval edema can lead to all these things as well. Okay. So, that is about edema. Okay. Icterus. What about icterus? When do you see icterus in a female with preeclampsia?
HELP syndrome.
HELP syndrome, very good. HELP syndrome. How do you diagnose HELP syndrome? What is the criteria?
So low platelet count, less than 1 lakh cells
Okay.
per cube,
Okay.
and there is a raised liver enzymes
Which are
Okay.
twice. And then
Twice the upper limit. Yes, correct. What else?
and
hemolytic
hemolytic.
anemia.
It's actually hemolysis.
Hemolytic hemolysis, not hemolytic anemia. It is not going to that extent. It is hemolysis. Okay. What is this diagnostic criteria called as?
Uh, not
It is called as a Tennessee criteria. Okay. How do you grade the severity of HELP syndrome?
sus.
Any classification?
Mississippi classification.
I would request all the PGs to not answer that quickly because these are UG students and we would want those UG students to answer. UG students can answer, but PG students can probably just wait for a while before answering. Let the kids think and answer.
The Mississippi classification, there is.
Mississippi classification. Okay, very good. What is the Mississippi classification?
There are three classes.
So there are three classes. So it is the platelet count, the AST, ALT level, and the LDH levels are seen.
Okay. Could you just tell me, but how do I make those classifications? Mild, moderate, severe.
Class 1, class 2, class 3. So
Okay. Class 1, class 2, class 3. What is the basis of that?
mm,
Your platelet count. Your platelet count is what is going to determine that.
Yes.
So your platelets, if they are more than, if they are between 1 lakh to 1.5 lakh, it is going to be class 1. If it is between, rather, if it is less than 50,000, it is class 1. Between 50,000 to 1 lakh, it is class 2. And class 3 is more than 1 lakh. So your class 1 is, in fact, usually your higher class is said to be the worst, but यहाँ पे class 1 is going to be the worst one. And hence, Mississippi classification is on the basis of your platelets. You mentioned about hemolysis. How do you know about hemolysis?
Sir, we could check for jaundice.
Jaundice. Jaundice is one of the last things that happens. Jaundice, remember, your bilirubin has to go above 3 at least for you to have icterus. Anything apart from that? It's a part of the Tennessee classification, Tennessee criteria.
So we can do a peripheral blood smear.
Peripheral blood smear, very good. What would you see on it?
So we'll find
schistocytes.
Yeah, cystocytes. Very good answer. Cystocytes, helmet cells, target cells, Burr cells, all these things. Do you know what is echinocyte? Echinocyte is basically spine-like structure, spine like a cactus. Your RBC that looks like a cactus. Echinocytes are seen in preeclampsia. Could you tell me why? Higher order question. Your Burr cells, your schistocytes, they are all going to be looking like semicircle, lunar shaped, broken cells. But you then see a spiny cell. Pure, it is all spiny in all its borders. Why? So, in patients with preeclampsia, there is also problem in the cholesterol synthesis. And cholesterol synthesis is going to make a difference in the cell wall of your RBCs. Because of this reason, the RBC cell wall or the cell membrane is going to be defective and it gives rise to an unstable structure which looks like spinous process or echinocytes. That is the reason because of poor cholesterol functioning or poor cholesterol metabolism, you get echinocytes in patients with preeclampsia. It has nothing to do with HELLP syndrome and do not mistake those cells as HELLP syndrome. It is an important thing to know even for your NEET PG if you're given a peripheral smear which has echinocytes but not cystocytes, not target cells, not Burr cells, then it is definitely not hemolytic anemia. It is just one of the signs of preeclampsia and liver-related cholesterol metabolism ka problem. Okay.
Yes.
So, okay. Then icterus, nothing, fine. Come to the next slide. Head to toe examination, absolutely nothing over here, nothing. Oral mucosa, no thyroid swelling, no stiffness. Breast is okay. Okay. What do you expect to see on abdominal examination? Expect. You don't have it here, but what can you expect in a patient with severe preeclampsia?
So there could be abdominal edema.
Abdominal edema. Okay. On inspection, on palpation, anything?
Uh,
Tenderness, epigastric tenderness. Right.
Yeah, tenderness, very good. Right hypochondriac or epigastric tenderness. Why will that happen?
Due to this
So, due to liver, the swelling of the liver or the hemorrhage in
Yeah,
liver.
swelling of the liver. Yeah, very close. Subcapsular hematoma. सबकैप्सूलर अरे ग्लिसन्स कैप्सूल लिवर के ऊपर ग्लिसन्स कैप्सूल होता है क्या रे मिहिर मेरे को जितना पता है ग्लिसन्स तो किडनी पे होता है ना यार आई थिंक सो नो ग्लिसन्स
No, no,
कैप्सूल्स
sir.
हाँ
Glissen's capsule is in the liver.
liver okay sorry so yeah so glissen's capsule के नीचे basically subcapsular hematoma is going to stretch the capsule any stretching of any ligament or any capsule is going to lead to pain and that pain the patient will either tell you herself or you would be able to palpate it and give rise to tenderness, right hypochondriac tenderness if there is a right-sided lobar hematoma or if there is a left lobe of liver ka hematoma, then that is going to lead to epigastric tenderness. Okay, now that I'm talking about all these signs, any other signs that you would see in patients with why would it stretch in preeclampsia, sir? It would not stretch. It would stretch because of the hematoma that has formed underneath its capsule. Why hematoma? Because of thrombocytopenia, there has been bleeding, and that is the reason that would lead to that subcapsular hematoma. Okay. Before going to severe preeclampsia, any other hepatic changes that you see in pregnancy in preeclampsia? Is my voice breaking? Is my voice
No,
not
no, no, sir.
clear?
Yes.
Okay. There's someone who said.
We
Okay.
just,
Tell me, any other hepatic lesion that you see? Anything on microscope? The
uh,
reason for your increase in transaminases?
um,
So the answer is hepatocellular necrosis. Hepatocellular necrosis because of blockage or anything to the blood supply of your hepatocytes that will lead to breakdown of your hepatocytes. Breaking down of the hepatocytes is going to release two things. सबसे importantly, SGOTPT बढ़ेगा, all your transaminases are going to be released, and because your cells are breaking down, they are dying, your LDH is also going to be raised. Any other cause of rising LDH in patients with preeclampsia apart from hemolysis?
uh,
By the way, telling everyone, since everyone is present right now, at the end of this session, we'll be giving you all a feedback form. Now, this session is something that is being done for free for everyone, while many other platforms charge a fee for this. So we would love to have your feedback for this thing that we are doing. We are giving a time, our resources, everything. So please do fill the form. Last time we had gotten a lot of responses. That was really nice to hear from all of you. We would love, please fill that. And also for your attendance and your certificates, you will need to fill that. So please do that at the end of the session. The link will be put in the chat via SIMSOG team. SimSog, if you all are listening, you could already put it. These people may just start filling it because we are almost done with 75-80% of the session. Okay, so any cause of rising LDH?
So where the tissue breakdown,
Tissue breakdown, very good. Which tissue though?
like liver, like hepatocytes,
Hepatocytes, okay. Your
and
RBCs, hepatocytes. There is
this
one more important organ where there is ischemia and there is breakdown of cells that is happening.
kidney,
No, very close. We have already spoken about it. Your placenta, your
placenta. Okay.
trophoblasts, your syncytial trophoblasts in your placenta are also experiencing hypoxia, as we have already discussed in the pathophysiology. And
Mm.
that is going to lead to, continuously, that is going to lead to your LDH rising. So remember, your LDH is a very non-specific thing. Your LDH being non-specific, remember that your LDH will increase whenever there is breakdown of any cell. So because there is an increase in LDH, the reason can be multiple, any cell breakdown, and it also includes a placenta. So your LDH rising in an earlier pregnancy, in your early gestation, is going to be indicative of breakdown of your placental cells and can in fact also be a very weak predictor of your impending preeclampsia. Okay. So that is it about LDH, a very dicey hormone, a very non-specific but a sensitive hormone, enzyme, not hormone, enzyme. Okay, next page. Systemic examination is absolutely normal. Respiratory, okay, normal vesicular. Anything that can go wrong, that can be wrong in your respiratory system.
Like there could be respiratory distress or
Respiratory distress, okay, or any other specific findings? Anything specific?
pulmonary edema.
Pulmonary edema, okay. Fine. Anything else? Okay, that's fine. Cardiovascular system, okay. Now that we have come to cardiovascular system, imagine you have a patient who had severe preeclampsia, the same patient, and once this patient had severe preeclampsia, she had a collapse. We have already discussed this case. Could you tell me what can go wrong in a patient with severe preeclampsia that can have its cardiac complications sequelae? So PPCM, peripartum cardiomyopathy, we have discussed this on a group as well. Peripartum cardiomyopathy, that can happen because of your all your SFLT2 and soluble endocline that goes and attacks your myocytes. Your myocytes are going to have damage, and that damage is going to lead to dilated cardiomyopathy and loss of systolic function, and that is going to be the cause of PPCM in severe preeclampsia patients. So your SFLT2 especially is a very crucial connecting factor. Okay, then chest movements, central nervous system, GCS is 15/15. The reflexes are normal. Reflexes, why should there be increase in reflexes in severe preeclampsia?
Sir, it's if it's because of if the CNS is basically there is a cerebral irritability, so because of that there can be increased.
Okay, irritability is a good answer, but what leads to that irritability?
The vasospasm in cerebral
Okay, the vasospasm and the edema. The edema that is global, पूरे brain के ऊपर, the cerebral cortex is entirely covered with edema, and that edema is literally irritating those neural endings, and that is going to lead to your chances of neuro excitation because the firing is going to be increased. So, what is the drug of choice for eclampsia?
Magnesium sulfate. Sir.
Magnesium sulfate. Very good. What is the mechanism of action of magnesium sulfate?
Sir, it's basically it will block the
We have already posted, by the way, the link has been posted in the chat by SIMSOG. Kindly, everyone, please fill the feedback form. It would really help us improve. We have, I believe, substantially made sure that the problem that had occurred last time doesn't happen this time. The team has done a great job at that. So please make sure that you fill the form. You'll also get the certificates and attendance with that. Okay. Yeah. So the mechanism of action of MaxSelf?
So it blocks NMDA receptors.
Very good. NMDA, good. One of them. There are 5 actions: A, B, C, D, and E. So you have mentioned the D wala NMDA. मैं NMDA वाला जो D है वो इसमें डालता हूँ. So D is mentioned. What is A, B, C, and E?
Sir, acetylcholine release will be decreased, like in the neuromuscular junction.
Okay, acetylcholine. Okay, that is not that great an answer right now because it is not going to cause blockage of acetylcholine. Something else.
It prevents calcium entry.
Calcium channel blocking. Very good. Calcium channel blocker is very important. What else? That is C. A, B, and E remaining.
It also causes it decreases the vasospasm. It causes.
Okay. How?
It relaxes the smooth muscles.
Okay.
And it also stabilizes the. It's a neuroprotective agent, so it stabilizes the fetal neurons.
Okay, okay. So the answer is A for adenosine blockade, adenosine agonism. B से है GABA, GABA, जो GABA का रिसेप्टर्स है उसको पोटेंशिएट करेगा, सो इनहिबिशन वाला एक्शन बढ़ेगा. सी से कैल्शियम चैनल, डी से NMDA एंड ई से ग्लूटामेट का जो ई आता है लास्ट में वैसे याद रखो ग्लूटामेट का ब्लॉकेड करेगा. सो दीज आर द 5 एक्शंस ऑफ मैग्नीशियम सल्फेट. व्हाट आर द रेजिमेंट्स दैट यू गिव इट इन?
So there is a
Pritchard and
Okay,
intramuscular and intravenous is juice pan.
Zuspan. Okay. Any alternative regimens that we don't use but that you know of?
Like a low dose will be there, sir, like Chaudhary and Dhaka.
Okay, Dhaka, Chaudhary, very good. And Sibai.
And then there
What
is
is,
past
yeah, tell me.
Krishnan Menon regimen is also
क्या
there.
बात है,
But
ये
now
सर
we don't use
तुम लोग के
this.
कॉलेज में होता है क्या यूज? डू
नहीं
यू
नहीं
यूज?
नहीं
no,
sir.
no,
This is
sir.
just
It's a past regimen.
अच्छा, past regimen. Wow, that is a nice. What did you just say? Krishna what?
Krishna Menon regimen.
Okay, good. I'll ask my KEM students to use this in their exam to get those gold medal answers. Right. No one is going to know this. That is how you win. You confuse, you either convince your examiner or you confuse them, and that is how you get good marks. Okay. So, now, what is Pritchard regimen? Quickly tell me.
Sir, Pritchard regimen is used in like intramuscular. So there will be loading dose and maintenance dose. So loading dose will give 4 grams of IV over 3 to 5 minutes.
Percentage? Percentage?
20%.
20%. Okay. What else?
And then later, after 4 grams of IV or 3 to 5 minutes, we'll give a deep intramuscular injection, 5 grams in each alternate
Each
product.
buttock. Okay. So 14 gram given. What about Zuspan?
So juice pan will give 4 to 6 grams IV slowly over 15 to 20 minutes.
Okay. Great. And then loading
Then
dose? Maintenance dose?
in Pritchard, we'll give 5 grams intramuscularly, which is 4 hourly apart in alternate buttocks.
Alternate buttocks. Okay.
So we
And
should
in this?
continue for 24 hours after the like
After?
last episode or delivery, whichever.
Very good. Very, very good. Okay. And Zuspan, what is the maintenance?
Juice pan is 2 grams per hour IV infusion, like
It
same
is
as
actually 1 gram per hour. 2 gram is only given for obese patients. 1 gram is enough actually. So 1
1.
gram per hour. That is good. That is okay. That's a great answer. I love the answer. You have a patient who you have given Maxilf and she convulses again. What do you do? She's done with her 24 hours ka regimen. She convulses again. Or maybe when you're already giving it, your 24 hours are on and your patient convulses. What do you do next? Do you again give Maxilf or do you go for alternative medication?
So the alternative.
No, that is the thing. You
Okay.
can again give the loading dose and then continue the maintenance. You again give it. Your Maxilf, if it fails once, you give it again. But if a patient convulses for the third time, then I have to do two things. First of all, I have to start it on some alternative anticonvulsant like levetiracetam, lacosamide, or anything. And very importantly, I have to also look at any alternative cause, and that is something that is not eclampsia. Because if magnesium sulfate is not controlling, then it probably is not eclampsia. It can be a hemorrhagic stroke or something else, meningitis, something else. I have to look at alternative causes as well. So I will immediately shift her for CT scan or MRI, at least one of them, if possible. So alternative diagnosis देखना बहुत जरूरी है. If not controlled, then I'll shift her to alternative anyway. But second time, if a patient convulses, then you give her magnesium sulfate loading dose again. Do not forget that. Okay. Your patient has a high creatinine. Can you give magnesium sulfate? Tanisha Chinu correctly answered yes, yes, yes. What's your answer, Sampritha?
It can be given, but we have to monitor the like the renal function.
Okay, good. The answer actually is if your creatinine is higher than 1.1, then you only give, or even one, more than one, you only and only give loading dose. You do not give the maintenance dose. You give some alternative therapy. Alternative like levetiracetam is a good one. If your creat is high, the bottom line is you can give magnesium sulfate, but only the loading dose, not the maintenance dose. The maintenance dose is going to be much more dangerous. That said, what are the signs that you have to be looking for of toxicity?
So where deep Respiratory rate is more than 16.
Is it more? Like, do you have, what
No,
are the signs of toxicity?
Sir, there is deep tendon reflex, brisk deep tendon reflexes, respiratory distress syndrome.
Respiratory distress syndrome in an adult. Oh my God. That is what I thought used to happen in neonates.
knee-jerk reflexes will be absent,
Absent. Okay. What else?
and there'll be urine output more than 30 ml per hour.
More than.
Mm.
I'm talking about toxicity. The signs of toxicity are going to be systemic. So you have to talk about every single system.
Okay.
So when you're talking about every single system, your deep tendon reflexes have to be absent. Your respiratory system, in that respiratory system, it has to be respiratory depression. You do not say respiratory distress syndrome. It is just respiratory depression. And by that, I intend to say bradypnea. Your respiratory rate will go down. In your cardiac, what changes would you see in your cardiac system?
So there can be cardiac arrest or
Okay, cardiac arrest is the last thing. Before that, something else will
bradycardia.
happen.
Hypotension,
Hypotension, no, not really. Anything else?
like
You are
arrhythmia.
right. Bradyarrhythmia, bradycardia is correct. So how would you diagnose bradycardia? Not just by pulse, but also by seeing prolongation of PR interval. Your PR interval is going to start increasing. Very important thing. So ECG करना बहुत जरूरी है. Apart from that, your renal system, what is the ideal urine output that is required?
Like,
So more than 30 ml per hour.
Per hour, very good. More than 30 ml per hour or more than 100 ml in 4 hours. Either of them is okay. That is it about all the systems. Apart from that, muscular system, paralysis. Your muscular paralysis is going to be your side effect. Your body will not be able to move at all. So, muscular paralysis, cardiac arrest, respiratory depression, depressed knee jerks, and lastly, your reduced renal output. All these things are very important to check for toxicity of magnesium sulfate. Any one condition in whom magnesium sulfate is contraindicated?
they're in myasthenia gravis.
Oh, very good. Myasthenia gravis. Any drug that you should preferably avoid with magnesium sulfate? Calcium channel blocker. You do not give nifedipine because it can potentiate the action on neuromuscular blockade and can lead to not neuromuscular blockade. It can have an overall action that is synergistic and can lead to hypotension as well as neuromuscular blockade. So you would want to avoid that. Okay. We're almost done. Next slide. So abdomen examination is normal. Next. Okay. Next. Okay. That is also fine. Next. Okay. What is your line of management?
So first MgSO4 is given and
Okay.
antihypertensives are given.
Okay.
And then, actually, since it is 28 weeks, since the fetus is viable, we have to terminate the pregnancy. Either through it could either be through normal delivery or through emergency LSCS. So we have to, that depends on the case. And in this case, we have an LSCS was done.
Okay. So in this case, would you prefer vaginal delivery or cesarean?
So cesarean.
Why?
So
Because the cervix is dilated 1 centimeter and
Okay.
there's minimal effacement is present. And then the station was like -2 on the
Okay. So one of the reasons that I will accept as an okay measure is your poor Bishop score. That's a better answer. Okay, I'll accept your answer. Ki cesarean for poor Bishop score is an acceptable answer. But is it the method of choice?
no, sir. Like if it's less than 30, like 34 weeks, where we have to give like magnesium sulfate regimen, and then like we have to delay the pregnancy for 24 hours.
What, delayed delivering the baby for 24 hours?
No, sir. First, we'll give steroidal therapy.
Do you wait for steroid action in a patient who has convulsed already?
No.
So, like normal vaginal delivery is preferred unless it is like the cervix is not favorable for normal vaginal delivery.
Okay. But cervix is not favorable. If the Bishop score is poor, then you can just induce her. You can just put PG2 gel. Why not do that? See, every female deserves a fair trial of labor. Just because a Bishop score is poor, you have something to change that. Remember, your convulsion has happened now. Even if you're going to deliver by cesarean section, the SFLT2 and soluble endocrine is still present in your blood. You can still convulse after the cesarean section. In fact, your risks of cesarean are much higher than the risk of vaginal delivery. Your baby, or your rather your mother, whenever she is going to have a cesarean section, if her intracranial pressure is raised, probably they cannot give a spinal anesthesia. Plus, if there is severe edema across all her body, there is also going to be laryngeal edema. So even intubating her for general anesthesia is going to be a very risky affair. And after all this, if the BP is persistently high, intraoperatively there are going to be several bleeders. If your patient is in HELP syndrome because of thrombocytopenia, you might have a lot of bleeding. You can have postpartum hemorrhage, intrapartum hemorrhage. During the cesarean section, you can have hemorrhage. I do not want all these risks. Also, you're doing a preterm LSES. In the next pregnancy, the risk of scar rupture is going to be significantly high, which is why vaginal is going to be my first preferable method of choice unless there is an obstetric reason to not do that. Obstetric reason can be something like previous cesarean, or if the current baby, because of its prematurity, is in breech position. So unless it is in breech presentation, or it is previous cesarean section, or there is something like abruptio placenta and the baby might die, I do not want to go ahead with the cesarean section. So no, at such a gestational age, the cervix does respond to induction methods, especially in previous normal delivery patients. The cervix is going to be amenable. Do not directly think that your cervix is not going to respond. It does respond. It definitely responds. You just have to be smart enough to know whether this patient is going to be able to respond to that induction of labor or not. But do not think that just because it is less, the gestational age is less, it will not deliver. We have delivered several patients, live babies at 28 weeks of gestation. Do not forget that. Also, remember that vaginal delivery is good for the fetus. The fetal head gets compressed. It is a stress factor. Corticosteroids are released, natural corticosteroids, and the baby does have a good heart outcome. The baby has good chest, has a good respiratory outcome. But remember that a cesarean section is going to not have all these effects. So all these factors have to be kept in mind before choosing the modality of delivery. Preferably, it is always going to be vaginal delivery. Okay. Then your cesarean section, vaginal delivery, that thing is done. Um, Magnesium sulfate is given. What else? Apart from that, what's your next slide?
So it's just the summary and the provisional diagnosis.
Okay, then. So now that this female has delivered, magnesium sulfate is given, she is fine. You do an MRI of this female just to check if there is any other cause. MRI venogram is what is ideally done. Venogram क्यों? क्योंकि brain के venous sinuses भी है, उसमें CVST, cerebral venous sinus thrombosis is one of the causes. In pregnancy, because of the hypercoagulable state, there can be cerebral venous sinus thrombosis that can lead to all these things as well. So do a venogram. You will also see if there is a hemorrhagic bleed. You will also see if there is press or not. The patient is going to recover. What do you advise her for subsequent pregnancy?
So, like, since she already had preeclampsia, we can give like low dose aspirin in the
From what weeks of gestation?
Low dose aspirin should be given before 16 weeks of gestation.
Okay, so from 12 weeks of gestation, you will start giving it. That's good. Apart from that, she will also do uterine PI and all those things in early gestation just to determine whether she is going to be having it again or not. What are the long-term side effects of having preeclampsia? Long-term problems?
It can lead to persistent hypertension in the woman.
Persistent hypertension, yes. What else?
There could be chances of ischemic heart disease.
Ischemic heart disease or any heart disease in future, and all cardiac morbidities. Okay. Anything about the fetus? A mother who had severe preeclampsia, the fetus was delivered, it was in the NICU, eventually it got discharged. Anything that the fetus will have in future?
Intrauterine growth retardation.
No, after it is delivered, right?
Neurodevelopmental delay.
Neurodevelopmental delay because of prematurity, yes. Anything else in the long term? So there is something called as, yes, increase.
Increased risk of cardiovascular diseases in
Cardiovascular diseases and renal diseases in future. They say that there is something called as Barker's hypothesis. Barker's hypothesis says that your intrauterine environment determines how your life is going to be ahead. So in a mother who had preeclampsia during her pregnancy, the baby at some point in the future is going to have early hypertension. The baby is going to have, whenever it grows up, it is going to have renal disorders at an earlier age. And all these problems are going to be much more common. This is the Barker's hypothesis. So then that is it about this session. Sampritha and Hemanth, you both were really good and you answered very well. There are a few basics that you need to be working on a bit, and I believe that is something that can be done with. That is okay. You would pass definitely this exam. Your marks I will be telling you at the end of these 12 sessions. So well done, Sampritha. Did it help you, Hemanth, Sampritha?
Yes.
Yes, so there's actually a lot of things we learned today, like from you, that are not there in the textbooks that we read. So like that's actually the discrepancy that we had, like in the text, like in Datta or the textbooks that we read, like there's a lot of information that is not there.
Yeah, exactly. There is a lot of difference between what you do practically and what is given in the book. So that is what I tried to bridge today. So glad that it helped out you as well. So everyone, thank you so much. I hope the session was good. Kindly fill the feedback form, and that is also going to mark your attendance. Apart from that, if there is any doubt, just let me know in the next 1 minute. I'll be waiting in the chat. If you all could explain the risk of PPCM, just let me know whether the session was helpful to you all in the chat. I am reading the chat. Until then, I also answer the questions. How can Leopold maneuver be done in 28 weeks? Ideally, it is done after 30 weeks, but in 28 weeks, you can probably see whether the fetal head is felt or not. You may answer that or you may not answer that in your exams. Preferably after 30 to 34 weeks, that Leopold grip is going to be much more properly elicited. Apart from that, could you explain the reason behind PPCM? PPCM, very simple. Soluble FMS like tyrosine kinase is the one that leads to your damage of the heart. Your heart is going to be damaged because of the soluble FMS like tyrosine kinase that increases. Apart from that, why aspirin only at night time? Nothing in particular actually. It is like you can even give it in the afternoon. They say that the effect is going to be much higher if given at the night time. That is the only answer. Premature breach is a contraindication. Absolutely, Joe Biden. So what a nice name. Premature breach is a contraindication for vaginal delivery because until 32 to 34 weeks of gestation, the fetal head diameter is more than the abdominal circumference. So during breech vaginal delivery, there can be head entrapment, and that head entrapment can lead to fetal demise during delivery, which is why anything below 36 weeks, you do not attempt a breech vaginal delivery. It is contraindicated because of head entrapment. In management of postpartum eclampsia, will magnesium sulfate help? Absolutely. Magnesium sulfate will help in any eclampsia. Gargi, please switch your mic off. Apart from that, there is something called as intercurrent pregnancy, intercurrent eclampsia. It means that a pregnancy in which there was eclampsia, but the pregnancy was not terminated and it went on for more than a week or two, and it proceeded despite having a convulsion. It is absolutely contraindicated and not supposed to be done. It was done earlier periods when they used to give medicines and they used to pull pregnancy. Absolutely nothing. 24 weeks pe aaya, just deliver, the fetus may die, that's okay. But do not pull the pregnancy beyond a convulsion. Relaxin in corpus luteum. Your relaxin is released by the corpus luteum, which helps to relax all your arterioles, spiral arterioles, that increases the placental perfusion and reduces the risk of preeclampsia in a normal pregnancy. Vaginal delivery is a choice. I just explained that, Shravanti. I explained that in detail. Please just, I have just explained it. I'll explain it on the chat again. Apart from that, then we are done with the questions. If you all have filled the forms, feedback forms, that would be great. I've already pinned the message, and that is it from my session. Thank you so much, everyone, and good night. This was a long session. I hope everyone benefited. SIMSOG, thank you, Harini, for conducting, and we'll see each other again on Monday. We have our next session on Monday evening. We'll post the details about it on Monday. Thank you so much and good night.
Thank you,
Thank
sir.
you, sir.
Good night.
Thank you, Sampritha. Thank you, Hemanth.
Okay.